Hello, everyone. Welcome to today's live broadcast, Epstein Barr virus infections, Pay Me Now or Pay Me Later. My name is Dr. Tiffany McKenzie, and I am a Scientific Affairs Manager of Infectious Disease, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by DiaSorin. DiaSorin is a global leader in the field of biotechnologies. For more than 40 years, the company has been developing, producing, and commercializing reagent kits for in vitro diagnostics worldwide. It offers the broadest range of specialty tests available in the immunodiagnostics market and continually invests in research and development. Using its own distinctive expertise in the field of immunodiagnostics to deliver a high level of innovation. For more information, please visit diasorin.com. Now, before we begin, we have a few important announcements. First, this webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit your questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button in the lower left of the presentation window. We'll try to answer as many questions live as we can. Second, you can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. And finally, if you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button in the lower left. And finally, I would like to remind you that this is an educational webinar, and this offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left corner of your webpage and follow the process of obtaining your credits. I would now like to introduce today's speaker, Dr. Hank Balfour, who is a professor of pediatrics in the Division of Infectious Diseases and professor of laboratory medicine and pathology. He also serves as principal investigator of clinical virology programs. Dr. Balfour is recognized internationally as an expert in the diagnosis and treatment of herpes virus infections, especially those due to EBV. Dr. Balfour received his medical degree from Columbia in 1966, completed his internship and residency at the University of Minnesota and Columbia Presbyterian Medical Center in 1968, served as a pediatrician in the Air Force at Wright-Patterson Air Force Base in Dayton, Ohio from 1968 to 1970, and then completed a postdoctoral fellowship in infectious disease at the University of Minnesota in 1972. He has been at the University of Minnesota faculty ever since, and he is board certified in pediatrics. It is now my pleasure to turn it over to my friend, Dr. Hank Balfour, for his presentation.
Thank you very much, Tiffany, and thank you for spending the time, all of you out there, to participate in our webinar today, which is focused on Epstein Barr virus and the many diseases that this virus is responsible for. Our learning objectives are to help all of us evaluate the clinical findings and the laboratory tests used to diagnose Epstein-Barr virus infections. We will discuss the probable mechanisms of EBV-spurred cancers and autoimmune diseases, and finally, assess approaches to the prevention of EBV infections. First, I'd like to introduce you to my laboratory and my laboratory group. We have Jen Grimm on the left, Max Schmeling on the right, and then in the middle is actually the oldest member of our laboratory, and that's Epstein-Barr virus itself. And I say oldest because this virus has been with us human beings for millions of years, and as such, it has adapted some very clever strategies to avoid our immune surveillance system. And this is a close-up of the virus. And one of the interesting things about this virus is that it has little surface projections like that You may think they're ears of this creature, but what they actually are is material called glycoprotein. The most expressed material on this virus is GP350 or glycoprotein 350, which is a target for immunization that we'll talk about in a little bit. This virus this one is actually able to talk, and it says you can pay me now or pay me later. This really refers to a series of commercials that the Fram oil filter company put out in the 70s and 80s. And the point is here, this mechanic is saying, you can pay me now or pay me later. And what he means is if you change your oil filter regularly, you won't have to pay a large sum to have your engine rebuilt later on. Well, this, I think, is kind of an interesting way to look at EBV, because a question that we ask is, are you better off getting primary EBV infection when you're younger or when you're older? And this is a fascinating unanswered question. Some would say earlier, because pre-adolescent children don't commonly come down with mono. They have a relatively mild illness, whereas adolescents and adults usually have full-blown mono. But some would say you're better off getting it later, because a fairly recent multinational study showed that children with MS were significantly more likely than matched controls to be infected with EBV. Also, in Africa, among Kenyan infants, younger age at the time of primary EBV infection was associated with higher levels of EBV viremia that persisted throughout infancy, leading the investigators to speculate that these infants were at higher risk for endemic Burkitt lymphoma, which is a disease clearly due to EBV. So, are you better off getting primary EBV when you're younger or when you're older? What do you think? And at the end of this webinar, I will suggest that there might be an alternative answer. The outline for this presentation is listed here. We'll first talk about history, because I think history is always a good way to get a perspective on where we are today. So we'll talk about the discovery of EBV and its connection with infectious mononucleosis. Next, we'll discuss a little bit about the epidemiology of primary EBV, particularly among college students, and its clinical manifestations. We will then discuss the laboratory evaluation of EBV and the staging of EBV diseases. Next, we'll talk about EBV-associated diseases or spurred diseases, cancer and multiple sclerosis being the main ones. And finally, we will talk about prevention of EBV infections. So history begins, in a way, in the 1880s, when a pediatrician, and I'm glad it was a pediatrician because I'm a pediatrician, by the name of Emil Filatov, described the syndrome and called it idiopathic adenitis. And from his coining of that term until 1967, the etiology of infectious mononucleosis was not established. The next historical landmark occurred in 1920 when two doctors at Johns Hopkins University described a condition that they coined the term infectious mononucleosis, and that stuck. And the important thing was that this disease really could be mistaken for early acute leukemia, which of course was totally untreatable in those days. The next important landmark in the saga is that doctors here at the University of Minnesota described the cells that were very typical in the peripheral blood of individuals suffering with infectious mononucleosis, and we contrast the normal mature lymphocyte on the left with these large so-called Downey, named after Hal Downey, Downey type 2 lymphocytes. They're large, 2 to 3 times bigger than a normal mature lymphocyte. They have very generous nuclear material, and they have a kind of a pale bluish cytoplasm. Then, in 1932, at Yale University, the discovery was made of the heterophile antibody test. And I want to stress that heterophile means something that is not related to the causative agent. And so a heterophile antibody test, which is a very good way to do point of care diagnosis of mono, which is really measuring our antibodies against mammalian red blood cells, particularly horse, sheep, or goat red blood cells, is not specific for EBV. And that is one of the problems with the heterophile test, although it does remain the mainstay in many situations to make the diagnosis of acute EBV infection. The story of the discovery of the virus is a later story than that of the discovery of the disease entity. And it began in 1957 when Dennis Burkitt, who was a pediatric surgeon assigned to Africa during World War II, stayed and continued to practice his surgical skills and discovered a disease that we now know as Burkitt lymphoma, which was a jaw tumor of children and frequently fatal. He went to the United Kingdom to talk about this, and in the audience was Tony Epstein, who heard Dennis talk, and then later arranged to get some cells from him, some of these Burkitt cells, and see if he could discover if there was a virus in it. And sure enough, in 1964, the team that Tony led was able to show that the Burkitt lymphoma cells contained a virus which looked like a herpes virus and was subsequently found to be a member of, but not the same as, herpes simplex, a member of the herpes virus family, EBV. The three individuals who published this landmark paper were Tony Epstein himself, Bernard Achong, who is an Irish virologist, and Epstein Barr. And the message to those of you out there who are contemplating a research career and want to get on in research, it's very important not to be the middleman, because this is Epstein-Barr virus, not Epstein-Achong and Barr virus. Then a serendipitous event occurred. The Henleys, Werner and Gertrude, who worked at Children's Hospital in Philadelphia, had requested some of the Burkitt cells, looking at exactly what they were and if they could perhaps get some method of growing them in the laboratory. And they were using blood from a technician who, in the course of a number of experiments, when her cells were combined with the Burkitt cells, nothing happened. But then she contracted mono, and after she came back to the laboratory, her cells were totally permissive for viral replication. And this was a key clue that EBV caused infectious mononucleosis, which was later clearly established and published in 1968. So now let's turn our attention to the epidemiology and clinical manifestations of primary EBV infection. We have been conducting a series of prospective studies at the University of Minnesota starting back in 2002. And one of the reasons to do prospective studies, of course, is that you have no idea what the natural course of a disease is unless you take all comers. That is, all of a certain population that have never seen EBV before are EBV naive, and follow them until they either leave your study or become infected with EBV. And so what we did was to recruit in the residence halls of the University of Minnesota, shown here, and published in 2013 a study that showed exactly what happens if you follow college freshmen throughout the 4 years of their undergraduate experience. We actually had over 500 freshmen screened for EBV prior infection, and we screened them by antibody against viral capsid antigen and Epstein-Barr nuclear antigen, and we'll talk about those antigens and antibodies against them in the context of how to stage EBV infection and how to diagnose various forms a little later on. More than a third, actually 37%, were EBV naive, and of those we enrolled 143 in surveillance and saw them for as long as 4 years. Over the period of surveillance, there were 66 primary EBV infections, and the interesting thing was, and this is essentially new news at that time, 59 of the infections, or darn near 90%, were symptomatic. So the textbook statement that 10 or 25% of subjects actually that get infected or sick is wrong. It's more the majority. And how does this acquisition occur? What we're looking at here is a Kaplan-Meier graph, or a life table analysis, and it starts out that all of the people are EBV naive. So that's 1.0 up there in the top left corner. Everybody is EBV naive, and then during the course of college, we see a steadily downward trend, which means individuals are getting infected as they go along. The interesting thing is that in the freshman year, we had an infection rate of 26 cases per 100 person years of observation, or 26%, whereas in subsequent years, sophomore, junior, and senior, we had a rate of only 10%, which has a very small p-value. It's quite significant. So that the major amount of acquisition was occurring in the freshman year, and we can kind of understand that because these kids are very liberated from their home environment and are sort of exploratory. And so then we said, well, how are they actually getting infected? Are they getting infected from use of various substances, from different diets? The only thing we could find when we assessed the number of risk factors was that deep kissing was the key to acquisition of primary EBV among college freshmen. And this is what we call our kissogram, where we're looking at 3 different situations. We're looking at individuals who reported to us during the course of the study that they had no kissing or sexual activity, individuals who reported deep kissing only, and then those who said that they were sexually active. And the difference here is very interesting. We called those that said they had no kissing or sexual activity bookworms, and the other ones are either kissing only or sexually active. The difference between these populations, there's no difference between kissing only and kissing with penetrative sexual intercourse, but there's a difference for both of them, quite significant, versus no kissing or sexual activity. And so it's pretty darn clear to us that kissing with or without sexual intercourse is the way that mono is spread. So it truly, truly is the kissing disease. And talking about the kissing disease, let's see what we actually find as far as signs and symptoms are concerned. Well, the top list here is a list of signs, which really means that these are things that you can see on a physical examination. And then the lower cluster is symptoms that the patient would report to you. And one of the things that I want to point out here is that almost all the subjects, when you examine them, have a red throat, that's pharyngitis, and have lymph gland enlargement, particularly of the posterior cervical nodes, and the nodes kind of behind the ears, or the posterior auricular nodes. Then there are a couple of findings that are unusual, but represent almost diagnostic for mono, and these are eyelid edema, and rash is notably absent except when individuals are given penicillin derivatives. This is an 18-year-old who is coming to us on the 3rd day of infectious mono, and you can see that he almost has his throat obstructed with 2 things: a very large tonsil, and now as we look a little closer, he has a large tonsil, and it's kind of almost stuck to this right here, which is his uvula. And we have seen in some patients uvulas that are so swollen and enlarged they look like a snake, and the patient would almost choke on them. You could imagine that he was extremely uncomfortable. This is day 3. Now, on day 8, he still has a red, beefy throat with some pustular exudate, and the uvula is still enlarged. These pictures indicate to you that infectious mononucleosis is not a nice disease. It's a nasty disease. Talking about one of the findings, which if it's present, is pathognomonic. That means that it's a clear relationship to a specific disease, is the facial puffiness and eyelid edema that we do see occasionally. Right there and there. This was a subject that I cared for when I was a pediatrician at Wright-Patterson Air Force Base in Dayton, Ohio. And here's somebody who came to see me just a few months ago. I asked her if she wanted me to cover her eyes for this presentation. She said no. She said, I'm so distorted that nobody would ever recognize me. You see the facial puffiness, and you can see the eyelid edema. Very, very typical of infectious mononucleosis. And so what have students all together in our prospective studies over the years taught us about Epstein Barr virus infection? First of all, the attack rate of EBV among college freshmen is about 25%, not any less than that. And when they get infected, 3/4 of them are sick with a median duration of illness of 21 days. That's a long time. The major route of transmission among adolescents and young adults is deep kissing. We also have found in these studies that you can detect the virus and you can detect antibody against it in the mouth and the bloodstream before the onset of symptoms, during the incubation period, which we believe is approximately 6 weeks. Because of the high attack rate, college freshmen are ideal subjects for a prophylactic vaccine trial that we're going to discuss a little bit later on. We're going to turn now specifically to the laboratory evaluation of EBV infection. And I want to emphasize at this point that this is an ongoing investigation. In other words, we still don't have necessarily the perfect answer to what tests to use and when to apply them to completely sort out the timing and the types of EBV disease. I'm going to show you some material from a textbook that has recently been published by the American Society for Microbiology called the Manual of Molecular and Clinical Laboratory Immunology. And this comes from a chapter that we wrote, and it looks at the recommended laboratory tests for the diagnosis and management of EBV infection, simplifying it to looking for past infection, in other words, immune status, or detection of very early or subacute disease. And what we're recommending here is that for past infection, VCA IgG antibody is the single best test, because virtually all of the subjects that we've studied who have acquired primary EBV infection under our surveillance are VCA IgG antibody positive. EBNA1 antibody is a good test too, but EBNA1 is not made by 100% of subjects. 3 to 5% never make EBNA1 for reasons that we don't totally understand, but that's the case. For the detection of primary EBV infection, I think that the heterophile test is probably the most widely used, and we recommend it with caveats. The caveats are that young children, particularly those under the age of 4, often do not make heterophile antibody, and so they're heterophile negative, and you could miss mono in those circumstances. Then also, it takes sometimes 7 to 10 days for the heterophile to turn positive, where the VCA IgM is frequently positive right at the onset of infection. So that's your alternative test. For subacute infection, we recommend a combination of VCA IgM and VCA IgG. Those should be positive for subacute infection. That basically is infection, say, after the first 3 months, but before a year after onset of the primary Epstein Barr virus infection. Now here we have a display of both viral activity, symptoms, peripheral blood material, and antibodies. First thing I want to point out is oral shedding. Oral viral shedding with EBV begins before onset of symptoms. The onset of symptoms is shown here in gray, and then persists intermittently for many, many years. And we think frequently the source of primary EBV infection for a naive person is kissing somebody who's completely asymptomatic, but who is experiencing intermittent oral viral shedding. Another point to be made here is that the viremia period is fairly short. Shown here. And the VCA, IgG antibody, and EBNA antibody, as we mentioned, are frequently positive and remain so for life, with the one exception that there are those few individuals who are EBNA antibody negative persistently for reasons that we don't understand. This now looks at the staging of primary EBV and assesses how we would use the EBV-specific panel of viral capsid antigen antibody IgM class, viral capsid antigen antibody IgG class, and the EBNA1 antibody IgG class to make the diagnosis of stage of primary EBV infection. So in the first instance of EBV naive individuals, of course, they have no antibody against any of these three viral antigens. In the acute primary infection, which we designate from onset to 3 weeks post-expression of symptoms, we have the VCA-IgM positive. The VCA-IgG, depending on whether you're looking at the P18 or the P23 component, will frequently be positive, but EBNA is always negative at that point. In subacute infection, which we're saying is 1 month to 3 months post-onset of illness, the VCA-IgM in almost all individuals will remain positive. The VCA-IgG, which was possibly positive in the acute primary infection, remains positive, and essentially 100% of patients are positive now, but very few patients are EBNA positive at that point. Then in convalescence, during the next 3 months, the 4 to 6 months after onset of illness, the VCA-IgM may persist, but it often has waned to undetectable levels. The VCA will be positive, and the EBNA is becoming positive, but not in every case. Whereas, if we look at past infection, that would be 6 months or more after the primary illness, we would see that the VCA-IgM has become negative, whereas the VCA-IgG and the EBNA are both positive. A question that remains to be answered is there a utility in adding an antibody test against early antigen diffuse? Would this really help us to sort out in controversial or difficult cases where the infection actually occurred, when the infection actually occurred? And this is something that's worth pursuing. Okay, here's another table from the ASM textbook. And what we're looking at here is not primary EBV in the immunocompetent host. We're looking at EBV infections in other situations, or more significantly, the area of chronic EBV infections. The first thing that we have listed here on the top row is monitoring patients post-transplant. And here, what is most commonly done is we look at the blood viral load. I will say that there are certain centers that prefer to look at plasma, and so the matrix is actually a little bit in question. But I would say the majority of centers are looking at blood viral load, and they use the amount to decide whether they should reduce the patient's immunosuppression, or whether they need to try to treat an acute EBV infection or not. So monitoring post-transplant EBV infections, blood viral load, that's the test that's used. It's usually a real-time PCR, and it's quantitative. The diagnosis of post-transplant lymphoproliferative disorder is not made by viral load or by antibody testing specifically, but rather by in situ hybridization of biopsy material for the detection of RNA EBV nuclear transcripts, or EBR. If one is dealing with hairy leukoplakia, which is an oral EBV disease, usually in subjects with very severe immunosuppression, such as late-stage HIV/AIDS, the diagnosis can be made clinically because the location of the lesions is very specific. But if it's a question, then in situ hybridization of a lesion swab or biopsy, or actually looking for DNA in that material, can be done. When EBV is suspected of causing meningoencephalitis, then PCR of the spinal fluid is the way to go. In the case of associated cancers, again, we rely on in situ hybridization of biopsy material for detection of EBV RNA transcripts, or EBR. This is a figure from a paper that Carol Holman in our group published a few years ago, looking at the utility of the height of EBV viremia for prediction or detection of post-transplant lymphoproliferative disorder, and these were solid organ transplant patients. And what we can see is that in subjects who have, proximate to the time of their diagnosis of PTLD, very low viral loads, less than 1,000, only 2.5% of these subjects developed PTLD. And the opposite is true in the situation of a high viral load of greater than 100,000 copies per mil of blood. Here, almost 1/3 of the subjects developed PTLD. So this is an example of how quantitative viral loads can be helpful in tracking the propensity for the subjects to develop PTLD in the transplant setting. I would now like to turn attention to one of the issues that is very much in need of prevention or treatment, and that is the issue of chronic EBV diseases, especially certain cancers and autoimmune diseases such as multiple sclerosis. First, let's remember that EBV is the first human cancer virus. Dennis Burkitt discovered Burkitt's lymphoma back in the late 50s, and then Tony Epstein in 1964 showed that those Burkitt lymphoma cells contained EBV. But in addition to endemic Burkitt lymphoma, EBV also causes Hodgkin's disease, lymphomas, usually B-cell lymphomas, but also sometimes T-cell lymphomas in immunocompromised hosts. It causes gastric carcinoma in approximately 10% of cases, and it is a very important cause of cancer among individuals of Chinese background. Nasopharyngeal carcinoma, one of the most common tumors among Chinese people. How does EBV exactly wind up spurring cancer? This is a figure from David Thorley Lawson's work that he published in the New England Journal a few years ago. And what it looks at is EBV infection in the context of the activity of the B cell after it's infected. And what is clear is that there are several potential areas where a block in the normal infection cycle can lead to malignancy. In the first instance, we're looking at what would normally occur in this direction here, where EBV would infect a naive B cell. That B cell would then become recognize EBV and become a memory B cell with memory for EBV, would exit the peripheral compartment and would basically enter a memory cell area where it would be not pathogenic. But there are two spots here in this process that can lead to malignancy. One is the Hodgkin's disease block, which is thought to occur when the germinal center B cell tries to enter the memory cell compartment and can't for some reason. And it just continues to circulate and proliferate. And if you have enough of that, you get a lethal, a malignant mutation, which can go on to become a B cell lymphoma. In the case of Burkitt lymphoma, it's a similar situation, except the block is at the dividing memory B cell stage to the resting memory B cell stage. What we see frequently in transplant patients, this post-transplant lymphoproliferative disorder, that's shown up here, where bystander B cells are incidentally infected with EBV. Cytotoxic lymphocytes get at those bystander B cells and kill them, but if we put on immunosuppression in the subject to keep the allograft intact, that immunosuppression will either reduce the number and the efficiency or the potency of the cytotoxic lymphocyte to kill the virus-infected cell, and it doesn't. And so you have circulating blasting cells, which, if they become monoclonal, can result in frank malignancy after transplantation. Let's turn now to a discussion of EBV and autoimmune diseases. And the best example we have right now, I think, is the connection between Epstein Barr virus and multiple sclerosis. There is no doubt that EBV is the major environmental risk factor for multiple sclerosis. And the evidence for that is that essentially all MS patients have EBV antibodies. And their antibody levels are elevated, especially against EBNA1, which to me suggests that there's virus activity going on that is constantly stimulating antibody secreting cells to make this antibody. Another point is that a history of mono significantly increases the risk of multiple sclerosis. And finally, investigators have found in autopsy tissue of MS patients who have died of very serious progressive MS, they have found EBV and EBV active transcripts indicating that there's EBV activity in the neuroinflammatory tissue of the brain. And so one interesting thought, which has been expressed here in a hypothesis by Dr. Pender, who is an Australian neuroscientist, is that you have to have a certain genetic makeup to get MS. And if that's the case, and you do not control autoreactive B cells, which find lodging in the central nervous system, and then, because those cells are there, antibodies that cross-react with myelin tissue actually then result in the plaque-like neuroinflammatory lesions of multiple sclerosis. There are other diseases, literally a myriad of diseases, that EBV is in part or completely responsible for. This list is by no means complete. It's just the major ones. Chronic active EBV, which can be fatal in young children. Chronic fatigue syndrome, also known as myalgic encephalomyelitis. Subacute systemic lupus erythematosus, and rheumatoid arthritis. Now, there also is a whole host of diseases, some of which don't even have a name, that have some of the findings of lupus or chronic fatigue or MS, and there's no real categorization of these. But I think a common thread through all of them is the generalized fatigue and joint and muscle involvement. And all of these could ultimately be found to be caused by EBV. I think this is a very unexplored and very important area for future research. Okay, so that leads me into the last area that I want to talk about, which is the focus now of our research, and that is prevention of primary EBV. And so here is an alternative to, is it better to get EBV when you're younger, or is it better to get EBV when you're older? I would argue that EBV vaccine could change all of this to, you don't have to pay me now, you don't have to pay me later, you don't have to pay me at all, because the virus is gone. The vaccine is taking care of it. Our hypothesis in our research program now to develop an Epstein Barr virus vaccine is that EBV vaccine given before primary infection will prevent or reduce the severity of infectious mono, cancers due to EBV, and multiple sclerosis. Imagine with me a college campus without mono. Even though it's not reportable, it's estimated that 125,000 cases are occurring among U.S. college students each year. Imagine a cancer clinic without Hodgkin disease. There are 200,000 new cases of EBV-associated cancers, including Hodgkin's, annually worldwide. Imagine a world without multiple sclerosis. Right now, there are more than 2 million people living with multiple sclerosis worldwide. It's not a nice disease. Right now, we have 2 EBV vaccines that have been tested in humans. The first one I'm going to talk about is the CD8 T-cell peptide vaccine, which has been used to literally induce production of EBV-specific cytotoxic lymphocytes from naive T cells. And then these EBV-specific cytotoxic lymphocytes go on to recognize and kill EBV-infected B cells. This concept has actually been proven in a paper a few years ago. The problem with this vaccine, however, is that it's HLA restricted, which means that you can't use it in every subject. And so the cost of producing vaccines according to HLA type would probably make this relatively prohibitive for a general population. Okay, what we're working on is a GP350 based vaccine. And you remember when we looked at the little doll figure of EBV, and we saw those projections. Some of you probably thought they were ears, but they're actually little groups of GP or glycoprotein 350, which is heavily expressed on the surface of the virus. This vaccine would induce antibody against that commonly expressed surface glycoprotein. And what we then do is we would block EBV infection, because EBV GP350 exquisitely recognizes CD21 on the surface of human B cells. And by blocking that entry spot, EBV cannot attach and penetrate and infect cells. So what are we doing right now at the University of Minnesota? We are in late-stage negotiations to obtain the cells that have been very carefully engineered to optimally produce GP350, and also all of the technical background material that goes with being able to produce our own material. Right now, our timeline is to finish the preclinical work on this GP350-based vaccine in the summer and fall of this year. And if the FDA is nice to us, and hopefully they will be, we would like to initiate at least a phase 1 clinical trial in the fall of 2017. This is an important avenue of research for the University of Minnesota. Our dean, Brooks Jackson, dean of the medical school and vice president for health sciences, has been quoted as saying, "We now have the opportunity to develop and evaluate a vaccine to prevent EBV infection, which has the potential to save millions of lives. I consider this research to be a top priority in the academic health center." And so, as we conclude basically the oral portion of our seminar, I want to leave you with my contact information, my email, my office phone, and the fact that development of vaccine is a long process and an expensive process. And I would certainly hope that some of you out there might at least consider a donation to our program. We have the University of Minnesota Foundation, which is a 501c3 tax exempt situation. So contributions to the University of Minnesota Foundation are 100% tax deductible and would help us very much to continue development of this vaccine. My highest priority, as I sort of am in the golden years, maybe some would say gray years, golden years of my research endeavors, my number one priority is to see this vaccine in individuals. I think it would certainly reduce the incidence and severity of infectious mononucleosis. It might prevent multiple sclerosis. I believe it would stop a lot of EBV-induced cancers, especially Hodgkin's and nasopharyngeal carcinoma. And hey, maybe all of those diseases that don't even have a name but have very severe chronic consequences for many, many, many people, maybe those diseases would be reduced or eliminated by EBV vaccine. In closing, I want to thank DiaSorin for sponsoring this, for LabRoots, for all of the technical and the presentation abilities. And I want to again thank those of you who took time from your busy day to watch this presentation. Thanks a million for participating, and I look forward to answering some of your questions as we have time. Do you want to say something?
Thank you so much, Dr. Hank Balfour, for that informative presentation. Before we get started on the question and answer session, I would like to remind our audience how to submit questions. You may submit your questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button in the lower left of the presentation window. We'll try to answer as many questions live as we can. And it looks like we have quite a few so far. Great. So our first question is, so Professor Balfour, you did speak to early antigen diffuse. Would you mind describing a little bit more of the utility of this antibody in the diagnosis of mononucleosis and how will its utility be resolved?
Yeah, certainly. The thing is that the more antibodies you test, the wider your spectrum of information is. And so it is possible that looking at the immune response to early antigen diffuse would in some way distinguish early versus middle versus late primary EBV infection. But we don't have those data. And so moving forward, we are hoping to do actually a study with DiaSorin to examine sera collected at various stages after primary EBV infection to see if the presence, amount, or absence of antibody against early antigen diffuse would be helpful in sorting out the disease stage and progress in those subjects.
Okay, thank you. Hank, we really look forward to the results of that study. So we have a really interesting question here. Let's excuse me. So something about reactivation of Epstein Barr virus later in life. So does a reactivation of EBV later in life put you at greater risk for autoimmunity and cancers, or does being older increase the severity of EBV infection?
Very, very good question. The reactivation of EBV actually occurs in everybody, but it occurs frequently. And we don't yet have information that it occurs more frequently in older people, but I would suspect that that is the case because a sister virus, varicella zoster virus, as we know, more commonly causes the reactivation form of the disease, namely zoster as opposed to chickenpox, in older people. And as we see, the amount of or the prevalence of it is greatest in the older decades, but we don't have that exact information yet for EBV.
Okay, thank you, Professor Balfour. Second, can you speak a little bit more to the mechanism of what we know about how EBV might cause gastric cancer?
Well, we don't understand exactly the mechanism, but what we do know is if you look at the gastric cancer cells, about 10% of patients will have the active EBV transcripts in those cells, EBV positive, in other words. And so we realize that EBV is actively replicating in those cells. Now, why certain individuals would get gastric cancer and then a subset of them go on to have EBV-specific cancer, we don't know. But the likelihood is that we have three things working. We have the environment, we have the host genetics, and we have the timing and severity of the initial EBV infection. All of these factors contribute, I think, to whether or not EBV spurs cancer or not.
Excellent discussion on gastric cancer. Now switching from diagnostics to therapeutics, we have a really nice question here. Is there a need for therapeutics for Epstein Barr virus infection, maybe specifically mononucleosis? Are there any therapeutics available or in development? Or is there an animal model of infection for us to test these therapeutics?
Yeah, all good questions. First of all, to answer the last part first, no. There is no good animal model for Epstein Barr virus infection, and that has been one of the things that has slowed development of an EBV vaccine, because you don't have an ideal animal model in which to test candidate vaccines. The role of therapeutics is kind of a mixed bag, and in an unfortunate situation that kind of parallels the vaccine experience, and that is development of drugs, specifically antiviral drugs against EBV, has been extremely slow. And we only have right now two drugs available, acyclovir or its bioavailable prodrug, valacyclovir, and ganciclovir and its bioavailable prodrug, valganciclovir. And these have never been subjected to rigorous clinical trials. And so that's basically what we have. There are a few other drugs in the pipeline, I think drugs specifically developed to treat cytomegalovirus, which is a sister virus infection, that have activity against EBV. Does EBV need to be treated? Does primary EBV need to be treated? In the college student with mono, you bet. If we had a good therapy, it would be certainly something that I would prescribe.
Hopefully we'll get some new animal models in research world pretty soon here and test more therapeutics. But so also continuing, so back to the cancer discussion, how well described is the role of EBV in the pathogenesis of nasopharyngeal cancer, and how does this co-occur, do we know, in the research with human papillomavirus associated head and neck cancer and or recurrent respiratory papillomatosis? Any information on that?
Yeah,
I know this is focused more on herpes virus.
EBV really has nothing to do with the other things except for NPC, nasopharyngeal carcinoma.
Okay.
And there's no doubt that EBV is causing the disease. You can find EBV there. You can see specific antibody profiles against EBV. 100% of NPC patients have had an EBV infection, usually in childhood, so the incubation period of this is quite long. I would think that one of the groups most interested in an EBV vaccine are Chinese, both in mainland and China and Taiwan, because of the fact that this is such a common cancer and pretty clearly related to EBV. In fact, the first trial, it was a small trial of EBV vaccine, was done in Chinese subjects to try to see if it was feasible to develop a vaccine to prevent nasopharyngeal carcinoma.
Interesting. We look forward to the next round of vaccine data, hopefully coming up in 2017. So now transitioning from therapeutics to cancer to, we spoke about multiple sclerosis and autoimmune disease. So if you have had an active past EBV infection, does that mean your likelihood of getting multiple sclerosis is now lower? Can you speak to the timing of EBV infection and environmental risk factor for MS development?
Yeah, the situation, of course, with EBV and MS is complicated by the fact that 90 to 95% of adults have antibody against EBV, the footprint of a prior infection, and yet only a fraction of those individuals get multiple sclerosis. But it is quite clear that EBV is related, because it is quite apparent that those individuals who have a multiple sclerosis-like illness without EBV antibody, the diagnosis isn't right. It has to be relooked at. Whereas with EBV, there's data that the earlier you get infected, the more likely you are to go on to develop MS. And these are data from a collaborative international study of multiple sclerosis among children. But there are clearly combinations of things that work to cause MS or not. And the genetic background of the host is very important. We know that because in monozygotic twins, if one has MS, the likelihood of the other one getting MS is quite a huge amount, maybe 10 times that of the general population. And then we see that in first-degree relatives of MS patients, the risk is about 3 times that of the general population, and so on. So the genetics is terribly important. And then, of course, there are environmental factors which have been explored in terms of exposure to sun, where you live in the world, and the incidence of MS relates to that, relates to in some way to vitamin D metabolism, and that's going to be interesting to explore, I think, among patients with EBV diseases, if vitamin D is somehow involved in host defense specifically against EBV.
Excellent. So the data do suggest that the earlier you are infected, the more likely is a positive.
The more likely you are to develop MS. So somebody who gets infected later on is probably not as subject to getting MS. But again, we don't have absolute information on that.
Very interesting. Going back to the seed question, pay me now or pay me later, putting autoimmune diseases in that mix is definitely a major factor. So now transitioning to the EBV vaccine. So can a vaccine be used in patients who have already had primary EBV infection to prevent further diseases?
Yes, a wonderful question. And we categorize vaccines really in 2 groups: preventive vaccines or prophylactic vaccines versus therapeutic vaccines. And there clearly is an effort, particularly in the arena of nasopharyngeal carcinoma, to develop therapeutic vaccines. That is, vaccines that would boost the host's immune response, even though they're already infected, but that might, get after the virus by stimulating the host to be more immune aggressive against the virus. And then there are efforts to basically take a person's cells out of the body, or expose them to viral material to make them very specifically recognizing that material, and then give them back. This is sort of a type of autologous passive immunization after the individual's been infected. So yes, there are efforts afoot to develop vaccines that are therapeutic, that are treatment vaccines for EBV-spurred diseases.
So, and I think we are just running out of time, so maybe we'll just have one more question here. So do antibodies against glycoprotein 350 cross-react with myelin components?
To our knowledge, they do not.
Okay. And then we have
one more.
And then maybe just one more question here. Can you speak to the value of viral load testing versus antibody testing in the diagnosis of primary infection, maybe from serum versus cerebrospinal fluid?
Yeah, well, primary infection, usually if you're dealing with the otherwise normal host, there are people who have used a viral load, but it's not cost effective in my opinion. I think the best way to look at the normal host is going to be, like I said, a heterophile titer, or if there's a question about the results, if you're worried that the heterophile is slow to develop, EBV-specific antibody, specifically antibody against viral capsid antigen IgM class is the way to go. Viral load I would not use routinely in the immunocompetent host. In immunocompromised patients, I think the same thing sort of obtains, except for when you're monitoring them after transplantation, and there you clearly would use viral load.
Excellent. Thank you for the wonderful discussion on EBV diagnostics, therapeutics, and a whole host of EBV-associated diseases. So if there are no more questions, I would once again like to thank Professor Hank Balfour for his wonderful presentation. And I would also like to thank our sponsor, Diasorin, for making today's educational webcast possible. And I would just like to remind our audience that today's webcast is available for on-demand viewing for 6 months, so through November 17th, 2016. And you will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward this announcement to your colleagues and who may have missed today's live event. So see you next time. Bye-bye.